Well, welcome everyone, and thank you for allowing us the opportunity to present this work. It seems Lydia, my postdoc, is still not able to join the meeting, so I hope I sent Kristen an email if she could email Lydia a new link, because really it's a lot of work that Lydia has done on this project. And so we started this project to look at what patient education is available for older adults with cancer and the caregivers. Really interested in to know what other centers have developed in terms of patient education to inform patients what geriatric assessment is, what to expect, and how it works based on our clinical studies where a lot of patients don't always particularly know what a geriatric assessment is. And then when we give recommendations, why it's important to implement these recommendations. So we did this review project. We don't have any conflicts of interest. It wasn't a funded project. And so we all know that patient education is critical for older adults to understand diagnosis, treatment options, and enhance their self-management skills. And patient education can improve patients' health literacy and help them make shared decision making if they better understand what the options are and how to manage side effects. And so we started looking in the literature, and we looked at other reviews, and we could only find one previous review on therapeutic health education for older adults. And that was published in 2016, but they only included 7 patient education studies. So we thought it is time for a new review and see what we can find about education to support older adults who are referred for geriatric assessments. And so our review question was really broad. It was really, what do we know about patient education materials developed for older adults with cancer and their support persons, and what do we know about the effectiveness in improving outcomes? And we were broad with any type of outcomes. And for this review, we used the definition of therapeutic patient education from the World Health Organization, where it's really a structured process that supports individuals living with chronic conditions to self-manage their own health. And it really, the key thing in this review is that we really looked at therapeutic education as it is carried out by trained healthcare professionals. So there's lots of other educational materials and websites, but we really looked at education delivered by trained health professionals. So that is the definition that we use in this review. And we use the Arksey and O'Malley scoping review framework. And so we started with the research question. Then Rui, the librarian at the University Health Network, did all the searches for us. So we did use Confidence for the screening for the study to select the studies, and then we abstracted the data. And then, of course, we summarized the results. And today we're here, consultation with stakeholders. So we would love to hear your opinion and your views on what we found and what the next steps should be. And of course, we're using the PRISMA Scoping Review reporting guideline for the reporting. And so, as I mentioned before, Rui, the health sciences librarian at the hospital, completed the searches for us, and we used Medline, Embase, MCare. And MCare is the searchable version of CINAHL, Cochrane, Central Site Info, and Scopus. And we did the search about a year ago, and we reviewed all the references of the included studies. And the full protocol was published earlier in the summer. So if you have more questions about the detailed searches and everything, that is in the protocol paper that is open access available here. And we also did our literature search, and where we looked at websites of patient support organizations, ASCO, ESMO, the European Oncology Nursing Society, the American Oncology Nursing Society. So anything that we could find to see what else they had. And so to be included in this review, obviously it had to be patient education materials for older adults. And so we included studies that had a mean age of the study population of 65 years and over, or did a subgroup analysis for those 65 years and over. And the intervention had to be patient education materials that targeted older adults with cancer and their caregivers for the active treatment phase. And what do we mean by that? So it's really patients who had a diagnosis of cancer. So we didn't look at cancer screening, and we looked at whether it was surgery, chemotherapy, immunotherapy, etc. but we really looked at the treatment phase. And so we didn't look at once the treatment had finished at survivorship phase. So we didn't look at lifestyle interventions for people that have finished the treatment. We didn't look at, for example, genetics screening of other family members to see if they were affected. We really looked at the active treatment phase. And the studies could be any type of study design, and they could have a control group or not. And we really looked at any outcome, whether it's knowledge, understanding, impact on health and healthcare use, etc. But the education had to be delivered by a healthcare provider. And we chose studies published in 2000 or after, so that everything we would find would still be relevant in the current context, and it could be published in any language. And so we excluded, typically as other reviews, the conference abstracts, thesis, reviews, editorials, and commentary. We also excluded studies that used combined intervention, and so we couldn't isolate what the effect of the education was. So it could be education combined with navigation, combined with patient portals, etc. So where there were more interventions than just the patient education. And we excluded studies that focus on a single symptom, such as pain, studies that focus on patient prompt list, because that just gives the patient questions to consider to ask the oncologist. But our patient education expert, Dr. Janet Papadakis, that is not considered patient education. We also excluded studies that focus on audio video recording of clinical consultations, because it's not a healthcare provider providing patient education. And we, as I mentioned before, we excluded studies that focus on genetic testing of family members. And so we used Confidence software to do the title and abstract screening and the full text review. And so we used 2 independent reviewers, and conflicts were solved by a 3rd reviewer. And the data abstraction, we made a modification here to the protocol because originally we planned to have 2 independent reviewers, but based on the number of included papers, which was 96, and I'll show you that in a minute, we adjusted this strategy to have 1 abstractor and a 2nd reviewer to check the data abstraction. And in case of any missing study information, we emailed all authors up to 2 times to retrieve their missing information. And as other reviews, we abstracted data on study characteristics, such as the country, aim of the study, population, etc. And we abstracted data on the patient education interventions, such as the aim of the education, materials, outcomes, etc. And so we use a narrative synthesis to describe the included studies and interventions, and we use outcome mapping to show which outcomes were studied. And for quality assessment is optional in scoping reviews, but we chose to do it so that we could describe the body of evidence in terms of quality of the evidence. And we choose the mixed methods appraisal tool, 2008 version, because that allows for inclusion of different study types as well as mixed method studies. And so this is the overview of the review process. So Rui, the librarian, identified almost 27,000 abstracts and titles for us. And after deduplication, we had to screen over 16,000. And after the initial title and abstract screening, we had 731 full text papers that we had to review for potential inclusion. And so we ended up with 93 studies included in the review. So much more than we anticipated based on the previous review that we had identified in the literature before. And so in terms of where the studies were conducted, most of the studies were conducted in North America or Europe, with over 3/4 in those 2 continents, and some were conducted in Asia, and there were 2 studies in South America and Australia. So it was really in North America and Europe where most of the studies were done. And in terms of what types of studies were conducted, we see that about 40% were randomized controlled trials, and about 20% were non-randomized controlled trials. And then we have about 25% that were descriptive pre-post single-arm studies. And then we have 13% that were qualitative studies that evaluated the education delivered qualitatively, and 2% were mixed method studies. And in terms of focusing the type of older adults with cancer included, we see that all the common cancers in older adults were represented in the study samples. And so in terms of the included studies, even though we wanted patient populations that were 65 years and over, we saw that the mean or median ages were high 60s or low 70s, but very few studies with higher mean ages. And we see that family caregivers were only included in 21 of the studies, where they really identify them as participants as well, but the caregiver characteristics were often not reported in the original studies. And we looked also at how these studies were funded, and we see that about 55 of the 93 studies were funded, and 29 received governmental non-profit resort, and 12 support, and 12 received industry report. 15 reported no funding, and the other studies didn't say how the interventions were funded. In terms of the educational interventions itself, most of them were delivered in the pre-treatment setting, so before the patient had started the treatment, and we saw that most focused on pre-surgery education. There are 22 studies that focus on radiation, so pre-radiation or pre-systemic treatment, and there were much less studies that focused on education during the treatment or after the treatment, near the end of the treatment. And so we also see that in terms of the education provided, it was really a mix. We saw videos, multimedias, written materials, in-person sessions, digital or online platforms, telephone calls. We also saw virtual reality, and several of the studies combined paper with video, multimedia, etc. And so what was the aims of most of these interventions? Most of these interventions were really focused on shared decision-making, to really clarify the treatment options for patients in the study. There was about a third of studies that really focused on prevention of side effects, so preventing of complication, bone health during hormonal treatment, and chemotherapy-induced toxicity. 18 studies focused on patients who were experiencing side effects, how to manage them, and self-care. And so these focus on symptom monitoring, medication adherence, and self-efficacy. And there were 15 studies that focus on improving understanding of the procedures or the disease itself. And so I hope Lydia joined, because this is really Lydia's skills in doing this. So this is the heat map of all the intervention studies. And so on the bottom, I don't know if my mouse is working for you, but we see here the different types of studies that were included. So how we organize them by the clinical trials, by the non-randomized trials, the quantitative descriptive. So the studies we typically look before and after the intervention with the survey, qualitative evaluations, and mixed methods. And so we see across all study types that most of the studies focused on knowledge or understanding outcomes, followed by satisfaction or acceptability. And we see also as well as on healthcare utilization, but some of the other outcomes were much less included. And the outcomes studied, which were the most common, was the same across the different type of study designs. And so we also did outcome mapping to show the findings. So as I said, most of the studies focused on knowledge and understanding of the treatments and procedures. And so we can see that in those studies that focus on that, we see generally that we have improved knowledge, etc. There are some RCTs that didn't show any differences, but in generally, most studies showed positive findings on this outcome. And then we also have perceived information or being enough informed. And so we see often high baseline and potential ceiling effects in these outcomes. And so the findings are here more mixed. In terms of health literacy, is there improvement in health literacy or ability to self-manage? We see that the findings are mixed. In terms of patients feeling prepared or ready for the treatment, and so studies are focused being prepared for scans, procedures, surgery, discharge. We see particularly that this improves us, that patients indicate they know what to expect. In terms of self-care competence skills, which typically focused on SOMA self-care skills, we saw that it improves or that the effect is maintained, but some trials showed minimal change. And in terms of the other outcomes, self-efficacy, we see that it often improves, that patients report improved self-efficacy. In terms of decisional outcomes, we see that the decision aids tend to reduce the decisional conflict and improve decision-related experiences. But there are some trials that had no positive findings at all. And regret is often not changed, decisional regret. In terms of coping or activation engagement, we see that it is mixed results. In terms of satisfaction, which was one of the other outcomes that was highly studied, we see that most of these interventions have high acceptability and patients are very satisfied with them. In terms of health behavior, adherence, in terms of diet, nutrition, bone health, etc., we see that it often improves adherence behavior. In terms of early symptom reporting, safety behaviors, we see that it improves when measured, but it's often not measured, and some more heterogeneous findings. In terms of anxiety and depression, those were also two outcomes that were often studied. And so for anxiety, we see improvements, that there is reduction in anxiety depending on the format, and some of the interventions also reported increased anxiety as a result of the intervention, particularly with web informations. In terms of depression, we didn't see any significant effects in most of the trials. In terms of other psychological measures used, it's mixed results, and the same for quality of life. It's mixed results. Oh, I think I had symptom assessment. So we see that seems to improve when interventions include monitoring and management strategies. Otherwise, it was inconsistent. And in terms of pain was one of the outcomes. We see very limited evidence, but some study report pain improvement in pain. And these are some of the other outcomes that were less studied. But I want to bring your attention to the caregiver outcomes, because we were particularly also interested in looking what interventions report about caregivers. And we already noticed that caregivers, even though they're included in studies, they're not described in the studies. And we also see that back in the outcomes. So there's very few studies that actually measured outcomes on the caregiver to see what the effect of the intervention was. And so in terms of caregiver anxiety and depression, it's very limited, but there seem to be positive benefits of the intervention, and the same for quality of life. And so there is very few studies that report that, but there is some positive findings. So in terms of the overall body of evidence, we see moderate to high quality studies included, and with consistent strength in intervention adherence. So the patient educations as delivered, most of the studies report that 100% of the patients receive the intervention as planned, and that they have appropriate procedures for collecting outcomes, etc. But the main weaknesses in this body of literature is that most of these studies were single-center studies with small sample sizes. Most of the trials don't report on the level of blinding, and there is some incomplete outcome data. And in terms of the non-randomized design, there's lots of studies that developed their own questionnaire, and so they didn't use validated questionnaire. And there's also little description about if there was any adjustment for confounding. And so when we did the Quay literature search, we didn't identify any studies or interventions that we already identified in our literature search. So we didn't include more based on our Quay literature search. And so overall, what do we know after doing this review? So we see that across the patient education interventions, that these interventions really have a positive effect on patient knowledge and satisfaction, regardless of cancer type or how they were delivered. And these interventions enhance patients' understanding of procedures, treatment options, and self-care strategies. And these interventions were highly acceptable to patients. However, many of these educational tools, it didn't lead to changes in the health outcomes. So even though they obviously, from a nursing perspective, we can say they are important and they improve knowledge, but it didn't translate in health outcomes. In terms of reduction in anxiety, we see that they do reduce anxiety and decisional conflict, particularly if these education interventions are used in the pre-treatment context. However, we started this review to really see what educational materials have been developed for older adults to inform them what a geriatric assessment is and the importance of following the patient, the recommendations provided by the geriatric team. And so none of the studies that we found has developed education materials for geriatric assessment visits. So that was clearly a gap. That is what we hoped to find, and we didn't find any. And in all these patient education materials, there was very little attention to cognitive impairment or how they adjusted the educational materials to accommodate patients with cognitive impairment. And of course, that is the group that would benefit the most from patient education or caregiver supported teaching. But some of the older studies even excluded patients with cognitive impairment. So we have a clear gap on patient educational materials designed for patients with mild cognitive impairment or dementia. And so in terms of the impact of health outcome, so it is understudied. So it seems potentially positive, but only few studies looked at outcomes. If you provide more education, does that reduce hospitalization or emergency department visits, treatment adherence? And there was even fewer studies that looked at things like cost in the healthcare system. So in terms of this review, there's clearly limitations in the literature. As I said, most of the studies were single center with small sample sizes, and most of the studies developed their own tool to evaluate the knowledge, the satisfaction, etc. And so that really limited comparability, but also many of these tools, they didn't explicitly state that these were validated tools. Few reported sample size calculation or power analysis, and so many of them included 20 participants or so. And so we don't know, it's probably that a lot of these studies were not adequately powered. In terms of the RCTs in generally were well done. They had sound randomization and baseline comparability, but they didn't describe the blinding of the outcome assessors. And of course, there can be bias if you're randomized to the patient education arm versus the arm with usual care with no particular educational intervention. We also can see that most of the evidence really comes from high-income Western countries, and there were only 12 studies in Asia and 2 in South America and Australia. So the findings of this review might not be generalizable to other settings. And even in the studies, we see that most of the included studies had urban, well-educated, high-income hospital populations. And so they don't explicitly may not be generalizable to patients that are from different backgrounds or those with limited health literacy, which we know that is a common problem in older adults. And even though we plan to evaluate the actual education tools, most of the educational tools were not available or accessible to us, so we couldn't evaluate the quality of the educational tools itself as we originally set out to do. And so in terms of promise for the future, we see that there were many digital and multimedia interventions developed, and they were very well received. And of course, that would allow scalability and standardization. But very few of these studies address barriers related to digital literacy, vision or hearing impairments, or lack of device access. They included patients that clearly know how to access these devices and access the education. In terms of caregiver involvement, that is also really a gap. We know in geriatric oncology, involving the caregiver is very important. It's important to make sure they are adequately understanding what the treatment is so that they can report side effects, etc. And so most of the study, even though they provided education, that patients and caregivers were included in the education sessions together, they didn't describe the caregivers, and they rarely measured outcomes to them. So it would be important for future studies to also look at their outcomes and see if we're meeting their educational needs as well. And so what do we think is implications for research and practice? So clearly we need educational tools to tell all the patients about comprehensive geriatric assessment and why that is important and how it works and how it can be helpful to them. We need to think about education materials to adapt to levels of different levels of cognitive function and health literacy, because that wasn't addressed at all. And we know that there will be more and more older adults and more older adults that would have cognitive impairment as well as cancer. So we need to make sure that we have patient educational materials to support them. And I think we need to look at outcomes that matters to patients also, such as functional decline, treatment tolerance, etc. And of course, we need to start using, or maybe we should make one because there were clearly none available, validated outcome measures that we can use to evaluate, and then we can also compare different interventions to each other. And of course, the last step is to really include patients and caregivers in the design and evaluation of these interventions, because none of the studies described that they were co-designed with patients, and that might increase relevant and meet the needs of patients and family caregivers. And so in conclusion, while we were surprised by the number of studies we found compared to the previous review, there are lots of studies that looked at education and the effect on knowledge and satisfaction. And so the education really positively contributed to that, but there is less information on how it impacts health outcomes or healthcare use. And of course, we have most of the studies that have limited generalizability because there were small samples, unvalidated measure tools, single center, and so mostly in North America, Europe. So we need more information about other parts and validated tools, and we need a tool for comprehensive geriatric assessment. And so we have questions for you as the audience as well. So do these findings resonate with you? Do you know any educational materials that we have missed? And what would be for your clinical practice a priority for developing patient educational materials? What are you missing in your practice to educate patients? And what outcomes do you think we should focus on in future studies? Maybe I'll just stop sharing so that we can see one another, and I would love to hear your thoughts. But we really set out to find education for geriatric assessment, and that of all the work we did, we didn't find any.
Thank you very much, Martin. So if you have any question, you can either raise your hand so that you can speak, or ask your question or comment, put your comment in the chat. So yes, Tracy.
Thank you very much for a great presentation, Martine. I apologize if you said this because I got interrupted by a student. But did any of the studies mention the types of educators as far as lay educators, promotoras? I'm on the third revision for Journal of Supportive Care and Cancer on the use of promotoras in education on geriatric assessment, and also in education in general, lay educators versus nurse practitioners. So did you look at that, or did you just did you delineate between the nurses and also I know you looked at outcomes. In fact, I luckily got a revision request from JSCC yesterday. I looked at using education alone delivered by an NP specialized to the disease site versus standard nursing education, but I didn't do it in older adults. In fact, my average age was 60, so that was a bummer. But anyway, it showed me that we didn't make an impact on ER visits, but we did make an impact on, we did linear regression analysis and binary. But we did make an impact on some symptom management engagement through Epic. So anyway, so I guess my question is, I know that was loaded, but did you look at any delineation on who delivered the education?
Yes, so for this review, we included education delivered by healthcare providers because there's lots of information about lay education and things like that, but we had to narrow it somewhere. And so we focused on healthcare providers provided education. We didn't look at if the outcomes differed by education provided, but Lydia, I see she joined. But I would say the bulk of the interventions, it was either the surgeon in the surgical studies providing the education or nurses in a lot of the other studies providing the education.
Okay,
but we didn't distinguish whether it was a registered nurse, practical nurse, nurse practitioner, and things like that. But we could see if studies reported that level of detail. But from the top of my head, I think we had mostly just registered nurses delivering the education.
Okay, thanks.
Please.
Yes. So, do you hear me?
Yeah.
Yes, okay. Thank you very much for your presentation. So I'm really interested in your work. Maybe I apologize if I missed a slide on the populations included in each studies. So I was wondering if it could be a selection bias on the characteristics regarding the cognitive status or educational level of patients included in these interventions?
Oh, there's definitely selection bias because the mean age, even though we recruited or included studies that had a mean age of 65 and over, the mean age is low 60s, high 60s, low 70s. And so we don't have studies with mean ages in the 80s. We don't have any details on the level of cognitive function. No health literacy was measured. And we see that most of the studies included highly educated participants.
There's a question in the chat from Liana Shin. Sorry if I don't pronounce it. So either you want to speak, otherwise I can read it. So were there tools that you would suggest to use based upon the literature to measure patient education?
I think there is no validated tool. I think that is what we really found, that every study developed its own tool and some validated with patients before using, but we don't seem to have like a quality of life measure like the EORTC that we can all use and compare to each other. We don't seem to have a validated tool. It was very focused on the particular education delivered on the site, and it didn't seem that studies and the RCTs, other than using things like the HUDs for anxiety, depression, use tools that previous studies had validated or tested in terms of measuring outcomes. So there was work to be done.
Great, thank you.
Beranger is suggesting a general self-efficacy tool may be useful.
I think a few did. I think we have a few of those as well.
Any other comments or questions?
Then maybe I can repeat my questions to you. What would be relevant outcomes that we should include in studies or focus on?
Hi, Martine. Great study. I'm wondering if, I know you mentioned that patients felt like there may not have been sort of measurable health outcomes, but their measures of uncertainty reduced and things like that. So it's kind of like a psychosocial intervention in some ways, providing education. So I wonder if that those measures like kind of how it might align with decision making or like patient independent, like I'm just not, the word's not coming to my mind, but like their ability to I guess their confidence in moving forward with on their treatment, that kind of thing. I don't know if there's a measure that measures that, but yeah.
Decision making was measured, and so there was a positive. There were some trials that showed no significant findings, that they felt that the decision making was improved, the quality of the decision making. In terms of psychosocial outcomes, those were measured, and so there was no impact on depression, but there was a reduction in anxiety. But there were also trials that reported increase in anxiety by exposing, I guess, patients to information they didn't think of or didn't anticipate, but that was rarer than how many studies improved decision making.
Yeah.
In terms of decisional regret, there was no change in terms of the intervention, but it wasn't the outcome that most of the studies did focus just on increase in knowledge and satisfaction with the information provided. The decision making was not studied in as many studies.
Yeah, because I find like even just the act of a patient having a CGA and sort of the informal education that goes along with that, patients like their satisfaction is pretty high, or they feel like, oh, someone took the time to do this. So in a way, it's very psychosocial interventions, even though they might not, we might just say, you're perfectly clear to go ahead with treatment. We have no concerns. Just the fact that someone actually took the time to do that is an intervention in itself, but I guess harder to measure. I don't know how you would capture that.
Yes, we discussed that with Sabir in other trials too, like with genetic assessment, how you prevent bad things from happening, but how do you measure
How
that?
do you show that? Yeah, exactly. Yeah.
That is also important. Tracy.
I think with education interventions, and I don't know what the average, because you probably didn't measure this, but what was the average follow-up? Because when you, as practicing nurse practitioner, your average, it's all about the follow-up. It's all about the follow-up of the, so you deliver the education regardless, and it's all, and you deliver it with the family there because it takes a village, right? So it takes a village to do everything. And the retention of the education is only about 25%. So it's all about the follow-up. So did you capture the average number of follow-up sessions or monitor? It's all about the monitoring. Okay. And that's what the CGA would help with. If everybody included the CGA in their education, and then somebody actually performed the CGA, that reinforces the education. So that was delivered. But what I found in my research is that the monitoring was missing. So education alone wasn't significant, although it did lead to symptom management engagement calls through the system, but it was the monitoring that was missing afterwards, because they only a certain percentage of that education was actually instilled in the patient. How the family helped, the more, but I didn't capture that data. I didn't, measure how many, how much did the sister, how much did the daughter, how much did education was retained by that family member. So that would be interesting for sure. But it's all about the monitoring. So I think educational interventions alone do not impact outcomes to where you keep them out of the ER, you keep them, less anxious, you keep the symptom severity in check or low. So there are essentially like 5 different things that keep symptoms managed at a low level in patients with cancer, and especially older adults, because now we deal with, I'm working in urgent care twice a month, and now it's like we're dealing with dementia, and people even with smaller degrees of dementia, but the family members are taking over, and they're like they minimize that dementia, but hello, it's an issue. So yeah, it's I think educational interventions are just they're multifactorial. They're not just education.
In the study, we focus on education intervention alone and not with other intervention, because then obviously they would have stronger effect, but then you can't see what the effect of the intervention alone is. And so most of the interventions were a one-time session with a nurse, and then pre-measures and post-measures, or it was a website that participants could access, or other materials that after they met with the nurse could access as many times as they wanted, but it was typically one pre-measure and one post-measure in the studies.
But it would be nice to see how long that, like more post measures, just because how much is retained, maybe 25% after the first, but then, if they're accessing it more and more, then maybe check it later to see what is retained later. You know what I'm saying?
Yes, it's a good point. We have to look. We didn't abstract the data yet, or it might be an abstraction table, but not in the paper we're writing yet. So we can definitely look at that. It was a lot more than we anticipated to find based on the previous review. So we were a little bit drowning in how to best organize it. It's work in progress. Hey.
Hi, Martina. Thank you for a really interesting and timely presentation. I think it's a topic that I think is coming up more and more as just, thinking about referring patients to CGA, and sort of that question of what are we telling them about the process, So really interesting presentation. Maybe just a question and a comment, if I may. My first question was just, I really was glad to see that you had included gray literature. I think a lot of the work around that patient information probably falls in that gray space often. And I was just wondering, in that search, just thinking where some of that information about CGA for patients might be, just even individual clinics that might develop brochures or handout for patients, before their first visit and things like that. Like I know we had something like that at the Jewish, and just, I don't even know how you would begin to gather or look for those sorts of things, but just wondering if you came across any of that. Like I know even the NCCN used to have a handout for older adult patients. I look now, I don't think it's there anymore, but just wondering if some of those sources came up.
So we looked at nursing organizations and organizations like ASCO, ESMO, and things like that. We didn't look at individual hospital websites and things like that, because it is an unfunded project, and I have several, like on our team we had several students involved, and Lydia, who's on the call, the postdoc, did a lot of the work. So we had to set limits. So we looked at nursing organizations for as far as the information was in a language and things like that we could read and things like that. But we didn't look at individual hospital sites in terms of what they have posted online about education.
Makes sense. And then just a comment, you were mentioning about outcomes to examine. One thing that strikes me would be uptake and acceptability of the appointments. I mean, that would potentially require delivering the education before a patient would come or be referred, or at the time of referral to a CGA clinic. But I wonder if having some information would increase the number, among patients and caregivers who are overwhelmed with appointments and things, if having a better understanding of the reason for a CGA would influence the number who are accepting that appointment. And then on the other end, I was thinking about your RCT and the adherence to the recommendations on the other end, and just whether information about, how some of these different recommendations from the CGA can improve outcomes, if it would influence their adherence to those recommendations.
Yes, and that's how we got started on this project, how we can improve adherence to the recommendations, because I'm sure most of you on the call will do genetic assessment here. Oh, I will do this after my cancer treatment finish, or it's not so important to me right now. And they don't see how exercising to prevent falls is important now to actually finish your treatment and things like that. So that's how we got starting into finding information to see what's being developed. And so we didn't find anything, unfortunately. But I want to put it back to Sophie and the nursing allied health teams now that I'm not on it anymore. Maybe it is something, a project to undertake to do some like environmental scan or some project where we would collect from geriatric oncology centers to see what handouts every center is has developed or is using to raise awareness about why you're being referred for geriatric assessment, why this is important, and see if that is something that other centers can learn from each other or benefit from, or things like that, to indeed avoid patients declining appointments because they have so many appointments. Why is this one necessary? Or when you get the response, oh, when you call for geriatric assessment in studies, but I'm not old, this is not for me, and things like that. So maybe
That's
it is
a
something
great idea, and I invite you to to present your idea to the upcoming forum. I think it will be in the coming weeks, months. So I forgot the date, but yes, sure. I think it could be great. We're thinking based on what Faye was suggesting. I think we can also use SIOG to look at a national level what they use at the hospital and so on. What if there is any tools they use or guide or whatever material that are not published and are used by. So we are reaching the end of, and we are over
yes.
the hours. There is one more question on the chat. We just read it. So for future research direction, I would be curious to know if education directed to caregivers, especially for patients with cognitive impairments, produce similar outcomes as what you found in this review, where education was directed to patients who are educated and cognitively intact, and also what else can be done for patients with cognitive impairment who could not be cognitively receptive to education interventions.
I think that is really a gap because a lot of the studies just excluded patients with cognitive impairment or didn't say anything about it or didn't measure it. But obviously we know that population is growing too. So we need to make sure that we measure that and look at those caregivers as well. Are we meeting the needs of those caregivers who do it alone and don't have the patient to fall back on if they don't remember the education?
Great, thank you very much. Sorry again for the feedback at the very beginning. Thank you for staying and joining us. And yes, so great to. And I think I forgot the date, but we check on your emails and SIOG website and also social media. There will be an upcoming forum for NAHS members and for to get to know when is the next webinar. Sorry. Okay, thank you very much again. See you soon. Thank you very much, Martin, for your great presentation, and take care.
Thank you, everyone. And email me if something else comes to your mind that you think we should look at or discuss.